Good afternoon. Welcome all to this session. The theme of today's session is on enhancing digital skills for healthcare personnel for improved service delivery. And I think if we go through the history of healthcare delivery in Kenya, you see that the emerging digital tools development, which include data and developments in artificial intelligence, the health workforce in the region as the frontline users of the technology, they must be equipped with the new skills, supported by policymakers who can be able to understand and implement digital health strategies and infrastructure to put to work effectively and safely. The session that we are about to have will explore the role of governments and the private sector in providing the capacity building to the health workers and improving the e-literacy in healthcare in Kenya. Welcome all, and our first keynote speaker for the day is Professor Frederick Chite Asirwa. Professor Asirwa is Executive Director for International Cancer Institute. Welcome, Prof, and the floor is yours.
Thank you so much. Let me share my slide. So I'm very privileged today to be in this group today discussing about digital skills for healthcare personnel and how we can actually enhance those skills to improve service delivery. As you've heard, I'm the Director of International Cancer Institute, but I'm also a consultant physician, a medical oncologist, and hematologist. Now, what are these digital skills or literacies that we are looking at? This basically, we are looking at the capabilities which fit someone for living, learning, working, also participating and thriving in a digital society. And this is actually off of Royal College of Nursing in the UK, that definition. And there are several skills that are really pertinent that must be developed, especially in the healthcare field. And these skills involve both skills, attitudes, values, and behaviors. And we generally group them into several domains. And some of the groupings that are found that have been very, very practical are these groupings of both digital identity, well-being and safety, communication, collaboration and participation, teaching, learning and self-development, the technical proficiency within the digital skills space and literacy, information, data and media literacies, as well as digital creation, innovation and scholarship. I'd refer all of us to our Health and Care Digital Capabilities Framework of 2017 NHS. And here we are looking at both from information, data, and content, whether it's content creation or content usage, as well as leveraging the content information that you create to pass on some specific ideas. Teaching, learning, and self-development. And this one, I'll look at some of the e-learning platforms that we have at International Cancer Institute and some of the ways in which this digital framework is actually assisting in reaching as many people, especially so during this COVID-19 pandemic that has taught us a lot in terms of not really having a lot of gatherings of face-to-face. And then important is communication and collaborating with participation being one of the key points in learning as well. Digital identity, well-being, safety and security is very important, especially in the digital platforms. And there are various levels for each of these content areas. There's level 1, 2, 3, 4, and depends on how much one is able to do things within each of these levels. We are looking at technical proficiencies. We've talked about mHealth and various apps that are assisting within the healthcare system. Creation, innovation, and research. Research being the driver of this, not only the digital space, but the driver of progress. Now, just a little bit, 1 minute or so about International Cancer Institute. We are a non-governmental organization that works with both governments and non-governmental organizations across board to improve the quality of cancer control in the region. And we have 3 major centers. We have Center for Data, Training, and Research. If you look within the Center for Data, we have Office of IT and Data, where telemedicine, telepathology, and EICI, our electronic platform that collects patient data for care as well as for potential research activities is put, as well as Office of Education and Training within the same Center for Data, Training, and Research, where we have our e-learning platform, and you can check this out on www.elearning.intercancer.com. And over the last year, we trained over 2,000 healthcare professionals. So you can actually already start seeing some implications of some of these digital platforms in terms of scale up to the number of people that you can reach within the shortest period of time. And it also has Office of Research, including clinical trials that are being conducted there. Then for the Center of Clinical Care and Community Outreach, where we really focus on early detection of cancers and the ability to intervene, and also integrating hypertension and diabetes in some of this early detection work is very, very important. And we do have Office of Clinical Care and Diagnostics, where we have the Cancer Center as well as Hematology and Research Clinic. And in this one, I'll be sharing a little bit about the virtual multidisciplinary tumor boards that we've been doing over the last 2.5 years, as well as initiation of teleclinics and telemedicine within this office to assist in the outreach clinics. We have about 15 outreach clinics that are participating in this. And then the histopathology lab, having one fully functional histopathology, immunohistochemistry, and grossing unit in one center is a good thing. However, it actually helps more if you can reach a lot of people. So leveraging technology to ensure that we have this digital pathology platform with UPath, that we can be able to review slides from far and wide, and also discuss with various other healthcare professionals across board is very essential. And within our HPV testing molecular lab and the lab, we also are in the setup for biobanking. And as you know, this is not only important for collection of big data in terms of genetics, as well as improvement in outcomes for patients being treated for cancer and other hematologic malignancies, but this is also very, very important potentially to look at therapeutic areas within our patients. Oncology pharmacy, we also have what we call International Cancer Institute access to medicine electronic system for ordering for drugs in our various centers. But also in the Office of Community Outreach, the teleclinics really help a lot of those outreach programs, and the Wellness Center. I won't go into so much details in those. Now, looking at what in our context, what have we done in the application of digital skills by healthcare workers in our various platforms? So we started off by assisting in the creation of telemedicine center at a national public referral hospital here in Eldoret. And this was several years ago, at the time when mention of telemedicine, people thought, what are you telling us? This is something that is so much into the future, we won't need it. However, I'll show you some of the progress in that. But it has progressed to the extent that now within ICI, as a different entity, we are doing telemedicine with 13 centers, and some of them are in the rural spaces, which is very important for quick consultation 24/7 and timely patient managements and referrals for treatments. Virtual multidisciplinary tumor boards. Initially, about 10 years ago, we established physical tumor boards where every cancer patient is discussed. And during these discussions, you have all these multidisciplinary team members. You have oncologists, you have radiation oncologists, you have nurses, surgeons, social workers, pharmacists, etc., including laboratory technicians, and just about everybody who is involved in patient care. However, as you know, these meetings of face-to-face had a lot of limitations in terms of the space where you could hold these meetings, of course, because the numbers started growing of people interested in attending these meetings and discussing patient care. However, one of the greatest limitations became the number of cases that could be discussed at any given time. And unfortunately, you could only discuss probably 2 or 3 cases when you already have probably 10 or 20 patients that you've seen that you need an input of a multidisciplinary team. And therefore, development 2 years ago of a virtual multidisciplinary tumor boards, initially set up on Zoom and Microsoft Teams, and now on our electronic platform, is very, very important. And I would say that for instance, even Thursday last week, we had more than 459 clinicians from Kenya and various parts of the world, the majority of whom from sub-Saharan Africa, attended our tumor board. And you wouldn't really have a room big enough for such a group of people. Yet it's made easier by using digital platform, and all of them are able to ask their questions and get some answers. And then it's important about data and data collection, and patient care is very, very important if we can be able to track the data that we are collecting, but most importantly, use that data, analyze it, and it informs not only policy, but also informs the clinical care and improvement thereof. And so electronic ICI system, which we call EICI, is based on open MRS concept, but we've developed a lot of electronic forms that are able to be modified to suit the circumstances for cancer care. And this is what we are using in all our centers as well as here at ICI. And the point of care, including things like when you are doing screening for breast, cervical, or prostate cancer, hardly do we carry any paperwork. We just carry some palm-top devices or laptops, and we are able to enter this data. This is very important, and healthcare professionals, healthcare workers across all cadres are taught on all these systems so that they can be able to interrogate the system, they can be able to print out reports, they can be able to give suggestions on improvement. And I've talked about the ICI, Access to Medicine, which is based off Revolving Fund Pharmacy program. And now, because not only is telemedicine so useful in physical space and beaming out to various centers, but now we've joined the Join platform based off of a Japanese invention within telemedicine. However, we've downloaded it onto our systems, and we are able to conduct a lot of 24/7 consultations, referrals, and patient care activities. And we have several consultants as well as various clinicians utilizing this system. It makes it much easier, improves in terms of logistics of getting patient care wherever they are and whenever they need it as soon as possible, or even just assisting in the referral patterns of these patients. One of the greatest things that we've implemented is digital pathology. And this one, I cannot say much about it because there is so much good that comes out of digital pathology. Not only do you get a lot of expertise, remember our systems have very few anatomic pathologists in any of our countries, including Kenya. And unfortunately, so we have a lot of cancer patients that need proper diagnosis before they get effective treatments and therapies. And one of the ways is networking these pathology platforms. And so that you can have on your platform a CNS pathologist, a pathologist that is involved in gynecologic oncology work, a pathologist for breast work. And therefore, we are able to scan these slides and share with pathologists across the world. And then the pathologists are also able to send us some of the slides so that we can review. The best thing about this is that you get not only quality care in terms of diagnosis, but it reduces also the turnaround time in terms of pathologic diagnosis. E-learning, I think there are so many forms of digital platforms of e-learning, especially during this COVID pandemic. And I think just about every institution of higher learning or of learning thereof has established a certain e-learning component. I would say prior to COVID-19, every year we used to train between 400 to 500 people. And during COVID-19, just over the last 1 year, we've trained over 2,000 healthcare professionals from Nigeria to South Africa to India and all the likes, including various places in Kenya, on various topics that are important to care, whether it's breast cancer preceptorship that are usually 8 or 10 weeks with 2 offerings every week for 4 hours that are dedicated to this. And we have various specialists from across the borders. And therefore, these kind of platforms also ensure that you can leverage the kind of professionals that are not necessarily within your reach within the country that you would have needed if this was to be done face-to-face. And you can leverage on that as well. So next steps in these applications, of course, teleradiology, and I'm sure there are several places within Sub-Saharan Africa that are already on this platform for doing teleradiology, including with using the PAC system as well. Within our telemedicine platform, we have Diacon, so we are actually able to, import full CT scans, and you're able to scroll down and be able to report on CTs, ultrasounds, and various other imaging techniques just on the telemedicine platform that we already have. However, teleradiology as a whole would actually really improve a lot of turnaround times, especially for staging. If you look at in cancer, for instance. We need to optimize on the digital pathology. There are so many opportunities in terms of optimizing digital pathology, not only in this setting, but also opportunities in terms of quality control for some of the laboratories, as well as being able to do accreditation of some laboratories using this digital pathology framework, where you can use various samples that are already uploaded on this to be able to measure the quality of various laboratories. And there is already a digital pathology accreditation framework by American Society of Clinical Pathology and other various pathological organizations. And as you get all this data, artificial intelligence becomes one of the things that is an obvious progression. And one of the areas we are looking at from International Cancer Institute standpoint is how we can use artificial intelligence for breast, cervical, as well as prostate diagnostics. Once we have so many of these pathology specimens within our system, working with various partners, we can be able to see what kind of algorithms that can be developed out of this to be able to suggest diagnosis, or even be able to assist in trainings and making proper diagnosis. And once we have all this and we are working together in networking, we generate a lot of data from this. The data that can be used obviously to refine AI, the data that can be used in training, data can be used in research, data that can be analyzed for various things, but most importantly for our setting, we are establishing a data science center that can be of use to various centers across the world, including the use of next-gene sequencing from our biobanking. So you can look at all these areas, that the skills that are being developed and that need to be learned by the healthcare professionals in the digital space have a lot of applications. And these are just some of them, and we shall be learning a lot more with the subsequent presentations. I'll only give an example of one of the public hospitals in Kenya that about 6 years ago, we were given this shell space and were told by the CEO of this hospital that if you can develop this into whatever telemedicine you are talking about, then this space is for you and your team to be able to utilize. And so this is how we started in this space. We started creating, we looked for partnership to be able to make the space into a good potential telemedicine center. This is how one of the rooms looked like. The space could actually house more than 200 people. This is just one of the 4 rooms, and they have double doors, so you can open up and have 200 people in one place, and they all have connection to the digital space. And this is one of the first telemedicine use that we put it into, having a professor from Europe and my team on the ground in Kenya learning a lot of information about colorectal cancer using this, where you can easily ask questions back and forth. This is just one of the uses. However, there are all these other applications that this center would be useful for. And we also have connected our own conference center to be able to connect to so many other areas around the world, and we can host meetings with people across the world. It's important also in terms of mentorship. Remember, healthcare professionals quite often, even when you finish your training and you finish your schooling, there is that aspect of mentorship that is very, very crucial to make you a very competent healthcare professional and an expert in your field. And this is one of the ways we've been doing it. I mean, we've been going to each of these sites and we sit in the clinics and work together with consultants and professionals in those centers to review patients together and all that. However, as we shall look at several areas in which telemedicine is helping in that, there were also issues of data capture where EICI, data capture like electronic EICI, that is important, that we are using in terms of capturing the information. I'm being told that these slides are not moving. Are they moving?
The slides are to bring them forward so that people can be able to catch up with you.
Oh, let me see. Let me stop and start on this side. Not so sure they are not moving. What was the last slide? Do you guys remember?
We just saw the first slide, and I think after that we didn't see another. So maybe you can try.
Okay, I can just. Are you able to see what I have now? The slide. Perhaps I should not. Put it full screen. Are you able to see the second slide?
Just manually change the slides. That's good.
I'll manually change them so that you can see, but I'll just skip through. So these are digital skills. These are the 6 elements I was talking about in the skills, and these are the elements themselves: information, teaching, communication, digital, technical proficiency, innovation. This is a little bit about International Cancer Institute I've mentioned, and this is one that I was actually talking a lot about, the various applications that we've actually put this to use in our setting. And you can see from telemedicine center creation, that's where I was on how we created it, to virtual multidisciplinary tumor boards, to EICI and point of care, as well as access to medicine and revolving fund pharmacy. We are using telemedicine via joint platform, as well as digital pathology, e-learning, and these were the next steps. So this is the shell space we are talking about for the public referral hospital. This is how we started developing it, and this is one of the 4 rooms of the public health hospital where we have 50 people can easily get into one of the spaces. However, there are 3 other rooms, so you can open the double doors and have 200 people attending this. But if you have 2,000 who needs to be part of this, of course, you have to use the electronic platform so that the rest can be beamed. And this is actually one of the use of the telemedicine center once it was operational. Here is where I was talking about mentorship. Initially, mentorship was very tedious, and we still do this, but we actually do a hybrid system where we still go from clinic to clinic and are able to see patients together with the teams and those clinics. However, now we are doing a lot more digital, using digital platform to do a lot more mentorship, including data capture. These people from various centers are actually being mentored in terms of filling in the electronic forms during a screening activity. And so this makes it much more efficient. If you look at electronic platform in terms of geographical coverage for the tumor boards and the centers where we are doing various tumor boards, more than 2,000 healthcare professionals trained. You can actually see from South Africa, Malawi, Burundi, Tanzania, Kenya, Rwanda to Cote d'Ivoire, Zambia, and Egypt. This would not have been possible if not for an e-learning platform. And one of the most important things is these virtual tumor boards that I've already explained, but you can see one of them where we are so many of us discussing various cases, and the cases could come from Malawi, could come from Ethiopia, or various rural facilities in Kenya. And we have experts from various countries that actually join these tumor boards to discuss the patients. And another area that this digital framework really helps, once you are finished with the digital part of it, there is the skills training, and where we have a skills lab, you're able to train healthcare professionals prior to them, handling the patients and learning from the patients. So these linkages are important, and actually part of it is beaming these skills training workshops online so that other people can be able to access and join. And then as we do various trainings, you can see if we go to the OR or the theaters and we are doing various, whether it's colposcopy training, lip training, and various surgical procedures, it's also important that all these are actually beamed electronically in a very, secure, space where people can actually follow along some of the skills training. And these are gynecologists on this training, and these are surgeons that are being trained on the current aspects of breast surgical skills. And many training programs online that could not have been possible, these preceptorships, CMEs, and non-clinical programs, including grant writing, introduction to data management, and research methodology, that are only possible because of being able to explore the electronic space. And then with this digital pathology service, a lot of things can be done in one center. However, this center acts as a hub and spoke, and so many other centers, and definitely patients benefit from this. What are some of the challenges? Everything is not that very rosy. Of course, there's quite a lot of training of healthcare professionals that is needed in appreciating the digital skills that are needed for healthcare. But most importantly, even just the importance of this kind, because most people are still in the very traditional of writing on paper and a lot of face-to-face. But as you know, this COVID-19 period has really taught us a lot that we can achieve a lot more if we are able to do a lot more on the digital space. And making the community aware, especially if you are to do a lot of teleclinics, patients come and they say, I want to see Dr. XYZ. And if they can't see you in clinic and you said you'll be on a certain computer somewhere giving some orders for the healthcare professional on the ground to see the patient and make a diagnosis and treatment, most patients will find that very interesting. And therefore, having a lot of spending some time, making awareness creating awareness to the community on these digital platforms and the importance of them is very important. An issue on reimbursement is not an issue we can solve now, but this is where policymakers come in big time, because it's important that if I'm consulting a patient in Meru or I'm consulting a patient in Mombasa and I'm in Eldoret, that there is a way in which the time can be recovered, and it could be as good as a proper consultation in clinic. And so aspects of reimbursement to encourage a lot more people to use this system would actually be important. And I've noticed coordination of these efforts. We need a very strong coordination backbone and communication at all times. Of course, as we've also mentioned, it's one of the components of digital skills. But internet setup in most centers is quite unreliable, and unfortunately so. It will be important for us to address some of the infrastructural needs that need to be done for some of these things to be useful. However, I think because of the high penetrance of cell phone services in most of our setups here in Kenya, it becomes a little bit easier. Then scaling up of support and partners is important. And I've said policymaker buy-in is important for sustainability. And so this becomes a challenge where some of the policymakers have not been educated enough on the role of digital platforms in terms of improvement of quality of healthcare delivery. And obviously, medical curricula is still lagging behind in years and perhaps light years in some of the centers where incorporation of these digital platforms is not really even taught or even mentioned. Yet this should actually be a component of some of these trainings. My last slide is what are the next steps? How do we strengthen teleradiology and use of the few radiologists that we have in our settings in sub-Saharan Africa or even in Africa in general, and some few resources that we have to maximize on their output, where somebody can do a CT scan on an ultrasound in Eswatini and it's being read in Eldoret by one of the radiologists. So somebody does, an MRI in Ethiopia, in Addis Ababa, and it's being read in Ghana. I mean, these are some of the things that we can look at. How do you improve that kind of networking to improve on quality of care without necessarily moving people around as much as possible to decrease on logistics and inconvenience of travel? Then obviously optimizing digital pathology and the area of artificial intelligence is really important, and somebody may speak to this. As we do this big data, coming together and figuring out what is the best way of creation of some proper analytics and some proper hypotheses with our data, and what can it be used to improve on the quality of what we are doing in a research form would be very helpful. Advancing telemedicine in the region, I realize this is a very easy way of reaching as many people as possible and with proper quality care. There is mobile health apps that are mushrooming everywhere, and they have been of a lot of assistance in various ways, whether it's mobile health apps for screening, for treatment, decision support, for even pharmacy, and for various forms, including deliveries and all that. I think this is something that should be embraced a little bit more, and a lot of community education being done towards this end. And lastly, we need partners, and partners are not only the partners that we are used to in terms of traditional partnerships, but even non-traditional partners that could be a very good component in terms of improving the uptake, but also the evaluation of the impact and ultimately the outcomes of this digital technology in assisting within healthcare. I just want to thank you so much for listening to me, and I'll be looking forward to robust discussion and question time. Thank you.
Thank you, Prof. I think this is the most inspiring presentation, and I think the reasoners have been able to learn a lot from you. We have seen a lot of technology applications in most health domains, and I think this is the way to go. We have seen a lot of attempts from your end to see how we can be able to make the technology the way of life. And I think you talked about how COVID-19 has actually been able to enhance the adoption and uptake of technologies. I would like to open up the space for a number of questions to Professor Asirwa. You just take about 5 minutes, and then you can go to the next presentation. Questions, some of you can be able to use a platform. You can also be able to type your questions here. I'll be able to I will be able to post them to the professor. And also, you can also be able to ask them directly so that can be able to respond to your questions. But I think this is a very amazing presentation that everyone would like to learn more about, and how countries can be able to use the same approach in improving the adoption of technologies. Most countries, we see that we are actually at the infancy stage in terms of adoption of telemedicine, that I think from what Professor Asiro have told us, we have been able to see that technology can actually be able to change most of the things that we have been able to, that we have been having challenges addressing. The floor is open. Let's have questions, comments, and then we can go to the next presentation.
Thank you, Onesmus. I can see one question here. Can I go ahead?
Yes, you can go on.
Yeah, there's a question here that says, one, there has been an existing gap on healthcare worker readiness to use digital space, mainly due to capacity issues. How have you navigated this challenge? That's actually a very good question. And I would say it's yes and not true as well, because we've realized that most of the hesitancy of healthcare workers embracing technology is only because they do not understand the concept of the technology itself. I have realized that, for instance, when we were doing things to do with electronic medical records, where we said we don't really want to be having papers in our clinics and losing files and not being able to trace a patient's treatment. And for cancer patients, sometimes you have as many as 20 charts over the years. And so when we showed the teams on the advantages of actually using this, we've noticed that there has been 100% uptake in those sites. But it requires a lot of preparation and a lot of training of the healthcare workers. And you let them give you the reasons why they would be hesitant to take that platform. Because if you just come and say, I want you guys to be doing this from today, they're obviously not going to do it. One of the areas I've realized is to just say, what are some of the aspects that you do have that are gaps in terms of your data management for cancer patients or healthcare patients? And usually they give some suggestions. How do you tailor your training to fit the curriculum needs of those in need of training? Oh, this is a very, very good question. And I think I will share with the team our training manual for 2021 with all the courses that we've come up with. Initially, we just started with about 20 or so courses. Now we are 50 plus courses and ongoing. And usually this actually comes out of the need of those people who are practicing, who are out there. So we'll have, like, for instance, a hematologist in Nigeria. When we were discussing about our lymphoma program, we had already developed lymphoma training, and they said, how about multiple myeloma? We see a lot of multiple myeloma in our setting. And so that actually informed us in developing a multiple myeloma curriculum. And we involve all the people who are part of this process, including nurses and various oncologists and various clinicians, so that we ask, what are the questions and aspects of this that people need to know? And then in addition to that, when you do these digital platforms, we also have to have a hybrid system where we include some skills component. And some of the skills component can be trained digitally. However, quite a lot of skills component would still need quite a bit of face-to-face. And therefore, we have to determine which of these skills are amenable to a digital platform kind of demonstration, or which are these skills that really require somebody to come in and so you observe them doing it with a patient in front of you. And I think getting the feedback from the trainees and getting the feedback from these practicing clinicians has been one of the best things that we do with every course, and it always makes us improve on the quality of the courses. So we'll share with you the curriculum document and you can have a look, and we are always welcome to suggestions on how to improve even further.
Thank you, Professor Sirwa. That's well answered. So I'd like to ask to go to the next presenter. Our next presenter is Paul Macharia. You can take the floor.
Hello, good afternoon. Are you able to see my screen?
Yes, we can see it.
Okay. Good afternoon, everyone. It's happy to be here on behalf of my multidisciplinary team. I'm going to make a presentation on how a human-centered design approach enabled us to get specific information to develop a health worker training platform. I'll take you through the background. Just as the earlier presenter has mentioned, there's a lot of need to build capacity. And in fact, the theme of this session is around capacity building. We looked or interrogated how we could health services to the population in need. Statistics show that quite a number of people have mental health needs, both in inpatient and outpatient. And even the ratio of healthcare providers to the needs or to the patients is extremely high. Also, as many of you know, there's a great rise in the need for mental health services during this COVID-19 period. This is some of the basis of why we decided to go ahead and think around how best to build an intervention. The WHO already has identified the potential of digital technologies facilitating healthcare workers build their competencies. One, we all know that there is a lot of need to build capacity. It takes a lot of time, and some of the capacity building efforts are in-service training already when you're working, not in college. And this varies with the needs, and some needs are constantly changing. One of the examples I want to use is the Kenyan e-health policy. It looks at how the shortage of healthcare providers can be bridged by using ICTs, information and communication technologies, to build the capacity of healthcare providers. And that will definitely lead to equitable access to healthcare, which is built around our policy and legal framework. So let's briefly talk about a human-centered design approach. Maybe some of you are hearing this word for the first time, or maybe you've heard it before and you understand.
Joseph, you're just very faint. We cannot hear you very well.
Okay. Can you hear me now?
Probably better, but try to move a little bit closer. Yes, that's better.
That's better. Okay, thank you. So I was saying I can pick from where Paul left before the internet interrupt. So there is these identified themes, although he was sharing this line from his side. As we know, there's a COVID pandemic in this world, and especially even in our East Africa and countries that are concerned. As we did the project, and we found out that most of the nurses and the workers, they were affected by COVID, and there was a theme that we identified. So persona one, a 10-year-old experienced nurse, said that reduced client traffic in some facility because of fear of the infection. Then there was another experienced nurse, 29 years old, who said that parents and the children are stressed. Schools, college, and universities calendar has been unpredictable, and you can bear with that. There was a lot of changes of universities. People have been sent home and back because of the closing or a lockdown on and off. Then the persona two, a 22 years old nurse experience, said that there was increase of workload. Schoolgirls coming in for ANC, that's antenatal clinic, and the maternity, and also the immunization. So that's also affected because of the COVID, and there was a lot of adolescent pregnancy is because of maybe of a lack of going back, continuing in their schooling. Then there was another nurse, experienced 20 years, who said there was an increase of drug use among adolescents, and these people are still coming to seek care. So that one was brought by COVID, because most of the question was how COVID has affected. On the question concerning how the technology can be used, or if they have ever used the technology, a 10-year experience nurse said, I think with the technology now, you are able to reach bigger numbers. You are able to reach bigger numbers and to reach right now with the social media. People are able to share their information, reach quite a big number, and that is quite true, even from what professors has elected on. A nurse experienced 12 years said, the best is to create a platform. There is no physical now learning, and also we remember there is a WHO, a model of going back to better. So this is like creating resilient. Other thing, yeah, am I okay, Onesimus?
Yeah, we can hear you.
And as experience 16 years. Okay. Found a phone-based training very helpful and educative, because could always refer back. Prefer to do a training on phone because I do it on my pace and when I have my time. This is, you can bear witness that when you have maybe data bundles or maybe offline, and you have your mobile everywhere you go, because it's mobile phone is just like part of our like basic things now. So the listener said that he can do it everywhere, not just maybe going to physical classes. Then another 12 years old saying that learners can learn at their pace and the convenience. That's very true. Then there was another theme when you ask them what they prefer, maybe to make it more better, and they maybe and even better than the one that people are using now. A nurse experienced 25 years old said, videos are easy to watch. Like now, when I can see you, so even a video is okay, so that I can watch later. If I want to watch at a particular time and I am not able to, I can do it later. You see, maybe if the nurses, instead of maybe them asking the standing leave, as we know, there's a lot of, maybe we don't even have enough health workers or manforce, so they can continue with their schooling where they are working, and they can do it maybe when they're in off, or maybe they are taking maybe a lunch or something, because they can do it on their own face. Then a nurse experience, not a nurse, a social worker, experienced 9 years, said that yes, actually computer animation could be useful, teaching aid. You see, they are very entertaining. They are very catching, and you would want to listen to them more. You can see this is one of the way, like animation. So when you do this human-centered, it's good for mental health, because like even in mental health, you need like maybe like occupying this person, relaxation technique. So for him, animation was very good, and it would encourage him to continue with the learning. So as you can remember, this very well is a platform where that health workers can create more resilient, or even our health system can create more resilient. They can even increase the number of the people who are trained in terms of mental, not only mental health, even other areas of health. And this creating hubs for these nurses where they can pop in their own time and assess and have something to learn. So I think after there, I can let my co-facilitator Paul to continue with the human-centered
Thank you,
design.
Joseph. That's a
Welcome,
good
Paul.
representation of what we were able to do. And thus far, we've been able to do exploratory work. Now we are at the development stage. And maybe we forgot to mention, but the content we are developing is specifically guided by WHO guidelines. And we are building it for adolescents, and more so adolescents with special needs, like maybe adolescents who are pregnant or living with HIV, but also the general population of adolescents. And since it's an iterative process, we will build an e-learning platform that definitely can be used by healthcare providers wherever they are, and be able to provide them with a platform that they can learn from. Next slide, please. So let's talk about the conclusions. A number of things stand out. One, there are multi-level factors to building a good solution. So that's why we're even using a human-centered design approach. So we work with a multidisciplinary team to better build and develop an intervention that works. Definitely, the healthcare providers need their capacity built. Why? Because there are emerging needs of mental health due to the COVID pandemic also. And we all know that it may not be business as usual in the near future. We need to do a lot to meet that need. The last thing that I'd like to mention in this slide has to do with why digital technology. It's portable, it's user-friendly, and it works in different settings, especially mobile phones. There is minimal setup needed to develop this, and that's why we are building around mobile phone technologies. Next slide. So we'd like to acknowledge the funding agency and also the study PI, Dr. Manasi Kumar. She was happy to let us do it on her behalf. And definitely the research findings represent what we learned, not the funding agency's perspective of things. And the last slide now, thank you. So thank you so much. And those are our contact details. Please feel free to reach out to us. Thank you for listening.
Thank you for giving us a platform.
Okay, thank you, Paul and Joseph. We really appreciate your presentation. I would like to go to the next presentation. And our next presenter is Eric. Eric from AMREF on the adopting mHealth for e-learning for health training in Kenya using community health volunteers. Over to you, Eric.
Okay, thank you. My name is Eric Kiringe, and I support monitoring, evaluation, reporting, and learning at AMREF Health Africa. And on behalf of my co-authors, I wish to present an abstract that we wrote for this particular conference. And it was about, and of course, a study that we did conduct for one of our COVID-19 response interventions. So the paper was on adopting e-learning for health training community health volunteers in Kenya, a case study of AMREF Health Africa's LEAP in the fight against COVID. So LEAP is an learning platform that actually facilitates learning, mostly for community health workers on various health topics. And it was deployed last year for one of the interventions that we actually partnered with Eisai Pharmaceuticals based in Japan. And actually, we are able to conduct an assessment just to look at the effectiveness of key messaging to community health workers on matters to do with capacity building them on COVID-19 response. So looking at the context, number one, of course, in Africa, we do have limited access. That's one of the challenges, that we have limited access to knowledge about preventive measures, especially at the onset of the pandemic. And of course, LEAP was also used in this case to facilitate engagement on various health issues at community level, and also allows learning regardless of geographical location. Given the speed at which we were to respond to the pandemic, LEAP proved quite helpful in the sense we did have lockdowns here and there. Of course, there were fears, people didn't want to interact much, so it proved a great virtual learning platform. So basically how LEAP works is on, it allows, of course, like I mentioned, there's virtual learning on any device. It actually hosts, facilitates learning. Content is delivered through SMSs and interactive voice recordings, or IVRs. The other one is that LEAP also facilitates quizzes just to measure knowledge retention among learners. And LEAP also facilitates peer-to-peer collaboration through group chats, similar to what we have on our WhatsApp, and learners are able to discuss various issues here and there. So LEAP was deployed in eight countries across the continent, but predominantly we work in two. We worked in two counties, that is Kenya and Malawi. That's where we've been working even pre-COVID-19. So looking at introduction to our paper, given the emergence of mHealth platforms, that in this case LEAP was used to address knowledge gaps, in particular case in COVID-19, but this was also made possible by the increasing ownership of mobile phones among communities in Africa, and also the increased network coverage in Africa. So looking at a different, looking at the global, looking at Africa, given that it actually accounts for 3% of the global health workforce, which is mandated to look after 11% of the global population. That this proves that there's a huge burden on the healthcare workforce. So it made sense that they were the first people that required this capacity building. So that is the CHVs, that is community health volunteers. In Kampala, I know they're in Uganda, they're referred to as CHPs, I believe. And it's made easier by the fact that they are drawn from their respective communities. So our study had the following objective. We wanted to unearth how key messages.
Eric, we are losing you. Try to adjust your location.
COVID-19 related messages, and especially we targeted persons that were attending community facilities within their communities, because during the pandemic, people did not really like the household visitations were kept to a minimum. We also wanted to unearth how well key messaging increased capacity among workers to detect and contain cases of COVID-19. The other objective was to our
we are losing you, Eric. Eric, we are losing you. We can't hear you very well. Eric, you can hear me? Try to adjust your location so that can be able.
And the intervention was able to reach 22,965 persons. So we started before we get to message deployment. We started with content development, of course, in collaboration with the Kenyan Ministry of Health. From there, we were able to go into the respective counties for engagement and also to sell the value proposition for this particular intervention. So we have all stakeholders on board. The other one was that the mode of delivery, we conducted the messages. The intervention took place for a 3-month period, and messages were actually sent. Messages were sent out to the community health volunteers on a bi-weekly basis. So the results that we were able to derive from the study was that actually the results we were able to get, just before we even move to the results, I wish to state that these focus group discussions comprised of public health officials, community health strategy coordinators, the CHVs, and we also had their supervisors, and we also had community members in these FGDs. So we're able to find out that there was increased during engagement with their respective communities this year. There was a positive attitude in terms of uptake of knowledge on preventive measures to do with COVID. There was also change in social behavior, more so in public spaces like markets, and when churches did open, CHVs were able to be, they were allowed to share information. Say in churches, they were given, say, a couple of minutes to be able to talk to their communities. For border towns, for example, in Taita Taveta County, where the county borders Tanzania, there was improved border patrol just to make sure we didn't have people passing through the illegal routes, because that is one way of increasing the chances of spread of COVID-19. There was also improved public response to identified cases and the curbing of panic and mass hysteria. For example, I'll share an example of in Kajiado County, where we had a shopkeeper who tested positive, and people from people who used to buy from his shop altogether stopped buying because of fears, and it took the intervention of community health volunteers, public health officials, to have recovered persons or recovered patients come and share testimonials of how they did test positive. They went through the management, and they're able to get cured of COVID. So that is when people started going back to the gentleman's shop. We did also have challenges, of course. The participants did actually share challenges, and one of them is that as much as we are sharing these messages, we do have certain areas in Kenya where literacy levels are a bit low, especially among the pastoralist communities. So that was a challenge because if at all you share a message with someone who's not able to read, so they may not be able to disseminate the same information. So there was also another challenge. There was also the disruption of monthly household visits that CHVs actually conduct. So that did affect the routine data collection. We did also have challenges for persons, for the vulnerable populations. These are the diabetics and hypertensive. There were these fears that, of course, if they were, say, go for the usual, like they have to take their medicine. So there was that fear of even leaving the house. So it brought this was one of the things that proved a bit challenging. There was also laxity among the public, especially when on the news, when we had the MOH officials announce the positivity rate for COVID was going down. So the public would then again start to relax until now the cases started, the case start rising again. There was also a bit of lack of basic protective and testing equipment among the community health volunteers. As much as to capacity build them, we want them to get this information to the communities. It was a bit of a challenge since they didn't have protective gear and also basic testing equipment like the thermometers. We did also have situations in the country, in Kenya, where the country was not opened up and we started having political rallies, etc. And it reached a point there was a bit of a conflict, like if at all this COVID is real, then why do we have our political leaders conducting rallies? It must be this COVID thing is all, these are just stories, yeah? It proved a challenge to our healthcare workers. We did have improved case detection and referrals, courtesy of community health volunteers. And we did actually have improved preparedness and response rate of the healthcare system. We did have CHVs or community health workers working very closely with the rapid response teams. So in case of suspected cases at community level, it was easier. The rapid response team were able to get to a particular household much faster than if there was no such collaboration did not exist. So before I'll share an example where a rapid response team yet again in Taita, where we had a person, like an ambulance getting a person from a certain village, and people would tend to shun even interacting with the guys left behind. So the community health volunteers were really key in trying to really quell the social stigma. So our conclusions from the study were indeed the key messaging, a way of doing things through LEAP, did lead to increased awareness levels. It did boost case detection and management and referral efforts. Key messaging boosted the preparedness and response rate of COVID-19. I think that's the end of my presentation. Thank you so much.
Thank you, Eric. Thank you for the good presentation. I would like us to spare the questions until the end of the session so that we manage the time. Let's now go to the next presenter. Our next presenter is Samuel Warusimbi, who is a system admin from Ministry of East Africa Affairs.
Good afternoon, good morning, good afternoon, good evening, everyone, depending on where you are. My name is Samuel Warusimbi. I work as a system administrator, Ministry of East African Community Affairs, Uganda. Allow me to share my screen. My area of research or study, and as per what ISTECO sent me, I selected mobile communication application for health, but for purposes of local consumption, I narrowed this down to a collaboration approach for service delivery in resource-constrained healthcare facilities. And I did this study 1.5 years ago, and I used the Rubaga Hospital, or Uganda Matters Hospital Rubaga, as a case study. together with my co-author called Wamema Joseph. Now, out of this presentation, of course, has the introduction, it has the background of the study, it has the desired state from the background, it has the problem tree, it has the objectives of the study, and it has the methodology of the study and the solution that has been developed out of this research. Now, to start with my introduction, I find it imperative to define what collaboration means in terms of healthcare. And basically, this is where you have health workers or medical workers working together and sharing information and knowledge in order to be able to have an enhanced decision making, which ultimately improves healthcare outcomes. WHO has also its definition, and it infers that collaboration happens when multiple healthy workers from different professions and backgrounds work together for improved healthcare. Out of this, it was noticed that the application of information systems, of an information system that can lead or support collaboration was desirable in the practice of evidence-based medicine. This evidence-based medicine is where you have medical workers working together in order to basing their decisions on the most up-to-date, solid, reliable, and scientific evidence. Now, in the study, it was found out that countries have inadequate health systems, and these health systems are prone to different problems and therefore affect the economic growth and productivity of the labor force. And therefore, there was need for an intervention that can help medical workers to share information and enhance their service delivery. Next slide. Therefore, most interventions in healthcare are desirable in order to bring about a situation where medical workers from different locations can be able to collaborate, given the situations that we are going through, because every country now is facing rough and complex challenges, partly originating from new pressures, such as prevalence of pandemics like COVID-19. We are faced with chronic illnesses, fragile populations, and of course, the intensive use of expensive healthcare technologies that are not easily affordable by resource-constrained countries. Now, to improve healthcare service delivery, healthcare organizations have implemented different systems, ranging from those that do data capture, reporting. For example, there are EPRs, there are electronic health records, electronic medical records, and others. But all these have been done, but little attention has been put on collaboration, which would enable medical workers to work together, innovate together, share information, and also be able to make informed decisions. Therefore, there are still collaborative failure factors that bring about a mismatch between the actual and assumed information flows in the healthcare processes, and that deters collaboration among medical workers, which also brings about or hinders quality healthcare service delivery. Next slide. This study further looked at various developed countries and what they have done in order to be able to customize solutions for our local settings. And globally, it is noted that Canada, Germany, United Kingdom, South America have implemented EHR systems for sharing patient information. And in our settings, we need to localize such innovations in order to fit our settings. Next slide. Now, in the background, also, the study found out the hindrances to collaboration, and it was found out that healthcare is largely comprised of individual operating entities, and each generating its own silo of information. So, and this makes collaboration or interaction among medical workers minimal. You find that in a hospital where you have different departments, you can find a department having its own information system. So basically, information systems are departmental centered, and they are not outward facing, but inward facing. They're not speaking to each other. You might find a hospital or healthcare with about 4 departments, but each generating its own silo of information, and that kind of situation hinders collaboration among medical workers. The other thing that was found out was the inadequate funding of healthcare systems, and this funding is greatly done by donors in the pilot stage, and when the objectives of the donors are done, nothing is done for sustainability, and this brings about issues with collaboration and therefore calls for development of local solutions. Next slide. The other hindrance is that such donor systems are customized to target specific program areas such as data collection, reporting. They are focused on HIV, malaria, and tuberculosis, and hence bring about fragmented systems that in the process hinder collaboration. And the other thing is that such systems focus more on monitoring and evaluation, disease surveillance, patient registration, data capture, billing, and the rest of it, but less and little is done towards collaborative service delivery. Therefore, those donor-aided systems, as some of you have seen the famous call on this called HICS, they are just a cut and paste solutions. Whereas they are effective in their mother countries, they are not effective in our resource-constrained facilities, and that brings about a design reality gap, which of course brings about issues in collaboration among our medical workers. Next. The other hindrance is that these donor-aided systems are further aggravated by several other challenges common to resource-constrained healthcare facilities. And these challenges include we have limited resources, such as financial and structural constraints. We have inadequate systems integration. For instance, where I did the research, there was a DSH2 system, then a clinic master and a vision, but these systems are independent and not talking to one another. Therefore, getting information from one system to the other was almost done manually, and that was time consuming, which in the end affects good quality healthcare service delivery. Then the other thing that was found out is the lack of accessible communication technologies. And I realized that there was a community ARIS workers program called ACT. And this program for the workers to get information or to take information to the main hospital, they had to move manually to get information from there and also to deliver information. And such that kind of situation, of course, hinders collaboration. It was also found out that there is low quality and expensive internet access in resource-constrained healthcare facilities. And of course, that brings about issues. And of course, unreliable electricity, which is always on and off. And for your information, this study is meant for resource-constrained healthcare facilities, including those in villages where we have issues with electricity. Then the other hindrance was lopsided ICT implementations. You find that healthcare centers in towns are more equipped than those in the rural areas, and that brings about a lopsided ICT implementation, which of course in the long run brings about issues in collaboration. The other hindrance that was found out is the hardware acquisition. Much as the prices have gone down, but still they're still unaffordable in most of our rural areas. And the other issue that was found out is proximity. There is there's geographical dispersion in terms of the medical workers themselves. You find specialists in different locations and cannot be able to share information easily. You find some services like imaging services not attached to hospitals themselves. They are far away from the hospitals themselves, and one has to move a distance from a hospital to an imaging center back and forth. All those bring about hindrances in collaboration. Next slide. So the desired state is such that when implementing workable collaborative technologies to improve service delivery, it is imperative to note that when making those decisions, medical workers ought to make sure that the decisions they make are based on the most up-to-date, solid, reliable, and scientific evidence. And that is a process called EBM. And for that reason, in the practice of EBM, collaboration among medical workers is vital and is important because it increases the team's members' awareness of each other's. They get to share knowledge and ultimately lead to continued improvement in decision making. And the degree to which collaboration can be practiced is thus dependent upon the availability of patient information, medical guidelines, clinical expertise, and technology as an enabler along the patient process. Next slide. So the purpose of this research was it was realized that there are few studies that had been called out that focus on a point of care collaborative tools. So there was need for further research focusing on existing systems with a view of identifying the associated gaps, the challenges medical workers face during collaboration, the opportunities available that call for communication and collaborative technologies. And this research is in tandem with that scholar, Anif, who recommends that future research should examine how IT-based knowledge repository can be used to complement computer-based medical guidelines. Now, the solution for this actually enables medical workers to get patient information, to get the history of the patient, be able to diagnose, and in the process, they can also be able to get medical guidelines instantly. Supposing a patient, say, suffering from malaria, where the moment the medical workers types in that, the system is able to display all solutions that can treat malaria. Next. To summarize my problem statement, I used a problem tree. Now, a problem tree is such that it has roots, and roots, of course, those are the root causes of the problems for collaboration. And then a tree has a stem, and then the branches or leaves are the effects of limited collaboration. Right from the bottom, we can see that the major cause or the major challenge of collaboration is limited resources in terms of finance and in terms of structure constraints. And that brings about dependence on donor fragmented systems, as I've outlined in my background. That also brings about inadequate digital infrastructure. That also brings about poor proximity of medical workers, and then unreliable electricity. All those culminate from limited resources and financial, which include financial and structural constraints. Now, with these ones here, those bring about limited collaboration among medical workers. And when you have limited collaboration among medical workers, you're bound to have medical errors done in the clinical workflows. And those medical errors are bound to bring about or mean improper diagnosis, wrong site surgeries, duplication of tests, and unexpected death. So basically that problem tree summarizes my problem statement. Next slide. Next slide. Next slide, please. Now, the main and specific objectives of this study the main objective was to improve collaboration among medical workers in resource-constrained healthcare facilities by developing and validating a collaborative tool. And this tool was expected to make improvements in collaboration, thereby enhancing healthcare service delivery. And to achieve that, the specific objectives below were used or are to investigate our existing health information systems, enable collaboration among medical workers. That was theme 1. 2, to investigate the challenges that medical workers in resource-constrained healthcare facilities face while sharing healthcare information and medical guidelines. And the other objective of the study was to determine ICT systems requirements that must be made to enhance collaboration among medical workers. And the last objective was to develop a mobile tool, have it tested and evaluated for applicability. Next slide. The research methodology, I may not go through in details, but I used the researcher used the research design, which was cross-sectional, because that would enable me to handle various themes at the same time. Then the sampling method was purposive sampling. And next slide. And then the inclusion criteria for the study, of course, Rubago Hospital was adopted because it has a community health workers program, which is a home care department called ACT. And these workers face a variety of information access barrier. That is why Rubago Hospital was selected to give an in-depth understanding of the situation on the ground. And then the selection criteria for informants informants were selected from various departments that included the administration and management department, because this handles supports strategic and administrative issues. Then the other department that was selected is the front office area, as this supports the admission of inpatients, outpatients, emergencies. Then the other one was the clinical area, which supports the core health processes of the hospital. And of course, the IT department, since that handles the healthcare information systems. And the other one was the resource center, because it is responsible for acquisition, dissemination of knowledge and patient records. Next slide. Interviews were used. Observation groups were also used. Observation was also used. Focus groups and documentary reviews were done to enhance this study. And that gives us the characteristics of informants of the different departments I've talked about. And all in all, 32 were interviewed. Next slide. Now, the summary of the findings is such that it was found out that there was a sharing information system in place, though limited in scope. some clinical services are easier and faster. The informants had positive and negative beliefs towards the current system, which is clinic master. And in the overall, the existing system has made business processes easier, though there are still some challenges. Next slide, please. And the challenges include there was lack of online information exchange for referrals to and from the hospital with other healthcare providers. Supposing in Uganda you are sending a patient from Masaka to Kampala, they have to just move with their manual papers. Yet the desired situation would be that such things can be done online, but by the time the patient is in Kampala or Mulago Hospital is already notified about the incoming patient. But such online communication is missing. There is lack of systems integration, both internally and externally. Then proximity of medical workers and healthcare facilities like imaging facilities. Then, of course, infrastructure limitations. I found out that in most departments, medical workers had to share computers. Computers were used in turns where the system Clinic Master I'm talking about was installed. And of course, there was lack of training, insufficient system functionalities, user resistance to change, and the fact that patient information and medical knowledge or guidelines are detached from each other. Those were some of the challenges. And there was also insufficient utilization of communication technologies. There are issues of outpatient clinical information correctness since it is done on paper. And the existing system was mainly focusing on data collection, and little was done towards collaboration at a point of care. Next, the summary of the findings such that, moreover, resource-constrained healthcare facilities have substantial operational shortfalls in their physical networks because of the high costs, geographical dispersals, and big numbers of the populace in rural areas. The use of wireless networks and implementation of well-structured mobile tool was realized can be a good solution for those challenges. Next. Now, the next brings me down to the artifact or the solution that was developed, and that is the system design and implementation. On one hand, I looked at the functional requirements, and on the other, the non-functional requirements. And just as they outlined there, the data capture and ingestion, it should emphasize collaboration, clinical acquisition management, storage, enhancing notification alerts. And non-function, we looked at, I was able to gather, the system has to be fast enough. There should be authentication in terms of users who logs in, when and how and why. Then accessibility, maintainability, user-friendly interfaces, and all that. Next. Now, this is just the system user management interface of the mobile application that the researcher was able to develop. And from there, you can see this is Rubaga Hospital Healthcare Workers Collaboration Application. And here, this is where the medical workers register so that they can start using the system. Next. The next interface shows us the patient management interface. And this is where we capture the patient information that can be used in collaboration when medical workers are carrying out their clinical workflows. Next. Then they will have that interface for patient referral process interface. In case a certain medical worker from a given location is referring a patient, say, to Murago Hospital. So they have an interface where they can fill the patient history, the patient details, and all those other things. And the moment this is loaded, the receiving hospital will be notified through an ambulance alarm that Masaka Hospital is sending a patient with this information ID and with this problem, with this diagnosis, and they'll be able to get all the patient history just within a fraction of a second. Next. And then this collaboration tool has an inbuilt kind of WhatsApp platform where medical workers can share information just through just typing in, be able to share guidelines, be able to share solutions depending on a given situation. Like I gave an example there. Hello, this patient seems so depressed. Did he disclose any personal information to anyone? And then you can see the response like that. And this is the core, the reason why this application was made, just to enhance collaboration among medical workers so that there is improvement in healthcare service delivery. Next. So that is how the research was done, and that is the tool that was developed. And that's all I've had for today. Thank you for your attention.
Thank you, Arisibi. We really appreciate the presentation. Looking at what has been presented by Samuel, you see that resistance is one of the areas that have been hampering the adoption of technologies. And he told us that in his telemedicine project, he has been able to achieve almost 100% compliance and adoption. Prof, what is the secret behind this that other countries can be able to pick from you so that you can be able to take that as a lesson that other countries can be able to adopt maybe a similar model that you have been able to use to be able to ensure that despite the fact that technology is not very much acceptable to the health workers and other people, they have been able to embrace it. It has actually become the part of life for the health workers. And secondly,
Thank you.
maybe I just want to ask maybe the last question. Maybe you can comment about what is your experience with the health workers in terms of adoption of new technologies. Thank you.
So thank you so much, Onesimus, for those questions. Very good questions. So one of the things that I've noticed, and when I started the issue of electronic medical records, it was over 10 years ago. And as you say, change is very, very hard for most people. Most people are very interested in continuing to just use paperwork. What I've realized is that involvement of the healthcare workers at the time when you are developing as well as piloting the instruments or the digital platform is very, very important for the uptake of the platform. Oftentimes we notice people bring a very good idea and then they send it to various healthcare professionals and they say, we want you to start using this. They don't know the concept behind it. They don't know how the information will be stored. They don't know where the server is the server, especially when you're dealing with patient level information or healthcare worker information, is that have you looked at all the regulatory areas that concern such kind of portability of such kind of information? So engaging the healthcare workers by doing a lot of awareness of the project, as well as what it portends to solve, what problems it's solving. Oftentimes when I talk to healthcare workers, they are themselves who give me the various reasons that a digital platform will help solve the issues they are facing. However, what they need is how can now the digital platform, because there are so many that you are discussing with them, would be part of the solution to the problem that they're encountering. And honestly, I've noticed once you involve them in the decision-making process as you build the program, the uptake is very, very good. However, the uptake is usually they will view with suspicion with any new project if they are not really involved. And then my impression and my relationship with healthcare workers and how they uptake, these digital platforms. Honestly, I have a very positive experience. And part of this positive experience is that any project or any digital program that you are looking at to assist with healthcare workers, remember these healthcare workers have a lot of activities they are doing in the clinic. They are the same ones counseling the patients, they are prescribing, they are social workers sometimes, like you have to call and assist with logistic support for patients to go back home and forth for the clinics and transportation. So you find they are already overwhelmed in the system. If you are looking at involving the nursing, remember, most of the ratio between the nurse to patients, even on the inpatient service, is very, very poor. One nurse sometimes is taking care of 20 or even 40 people, and they don't want anything that will add onto the issues and produce more problems on already the list of overloaded work that they have. So showing the technology that is very user-friendly, the interface that the nurses or the healthcare professionals, the doctors, the lab technicians, the pharmacists, the interface that they are working with needs to be so user-friendly that it does not really encourage a lot of duplication of resources. I'll give an example. If you have an electronic medical system that a nurse, when the patient walks into the clinic, the nurse fills in the vitals and fills in some aspects of the history. When now the patient comes to the doctor to be seen in the clinic, that information should already be there. The doctor should not start by going back to the nurse and asking, what are the vitals for this patient? If you have that kind of break in the system, people won't like it because it's double work for the people to do. So I really think, and the previous presenter mentioned it very well, that if you end up in one hospital with 4 different systems that don't speak to each other, you find that you are creating a lot of work for the healthcare professionals, and they won't have a good experience with the digital platform. So it's actually how you bring it, and most importantly, let's create so much awareness of the importance of this and work with them on iteration of the same system to ensure that it's actually responding to their needs and not our needs as perhaps developers on the other side. Thank you.
Thank you, Prof. Thank you, everyone. Thank you, the other presenters. I really appreciate the presentations. We have learned a lot from you. And I think many listeners who are here would actually bear me witness that we have been able to witness a new level of technology application within the health sector, which has not been seen before, especially in the area of telemedicine. And I think this is an eye-opener for us as countries to make sure that we can be able to learn from what has been done by this team from Kenya, which is led by Professor, so that we can also be able to roll the same back in our countries. Thank you, everyone. Thank you for attending this session. And back to the team.